Hello everyone, welcome back. Today we'll discuss about respiratory system. One important thing I would like to tell you in respiratory system, whenever the question is asked by the examiner must have to tell you the symptoms of the respiratory system. Shortness of breath, cough, wheeze, lower limb swelling are all the symptoms of respiratory system. Examiner would make or would follow permutations and combinations in these symptoms mixed with the clinical findings and then ask you about pulmonary diagnosis or diagnosis related to the respiratory system. So clinical examination is very important in respiratory examination. Say for example, in USMLE step 2, there are questions based on the examination findings. I'll tell you some of the important findings which can club our discussion today so that everything will be in place. COPD patients do not have clubbing. True. COPD patients, if they have clubbing, it indicates that the patient has developed the malignancy. Yes. So most of the times the examiners frame a question around this, saying that somewhere in 4 to 5 statements, the examiner drops a word called clubbing in a COPD patient. So do not think anything. He's talking about development of malignancy in a COPD patient. This is what the examiner is talking about. Somewhere along the lines of the question, you find the pneumonia. Somewhere along the lines in the question, you find temperature that is increased. Think of consolidation, think of pneumonia, think of lung abscess. However, for lung abscess to develop, you will possibly need malnutrition, alcohol, no fixed abode, patient on steroid, patient has got HIV. All these are the things that you'll have to think of whenever the patient has got lung abscess. Talking about pneumonia, the examiner wants you to understand that a repeat chest x-ray needs to be done after 6 weeks just to make sure that the infection has been resolved. Why? Because the examiner wants you to understand that there may be underlying bronchiectasis that is developed in patients who have got recurrent pneumonia. Or patients with cystic fibrosis, they can present with recurrent pneumonia. Or patients with foreign body blockage can present with recurrent pneumonia and can develop bronchiectasis. Patients with malignancy can also present with recurrent pneumonia. That is why the examiners wants you to test this. Somewhere along the respiratory lines, the examiner will tell you that the patient has got dullness on percussion, stony dull on percussion. It is pleural effusion until otherwise proved. If it is increased, dullness is percussion is increased, or if it is hyperresonance, it is pneumothorax. Examiners would love to talk about atelectasis because the most common cause of atelectasis in post-operative cases is atelectasis. The most common cause of fever post-operatively is atelectasis. Do not select any other diagnosis until otherwise proven. Same thing, the examiner can talk to you about post-op with mild fever but increased shortness of breath. He's talking about pulmonary embolism. Please do remember that. Same post-op patient can present with decreased blood pressure with mild chest pain, or the examiner can use as a mild discomfort. He's talking about myocardial infarction. This is one thing you'll have to remember. All right. Now we'll see what are all the important conditions the examiner can ask. Normal lung, the breath sounds are bronchovesicular, tactile fremitus is normal, percussion is resonance, and mediastinal shift, there is nothing. Consolidation, there can be dullness, but please do remember that there is increased breath sounds with the temperature. Pleural effusion, we already discussed, percussion is dull. Pneumothorax, there is hyper-resonant, please. Hyper-resonant on percussion. Atelectasis, there is again dullness on percussion, but for atelectasis, you to consider it is usually the post-operative patient or patient with asthma or patient with COPD obstructed by mucus plug. These are the things you'll have to remember for atelectasis. Whenever there is atelectasis, there will be mediastinal shift towards atelectasis, and whenever there is pneumothorax, there will be mediastinal shift away from the tension pneumothorax. If there is a large pleural effusion, the mediastinal shift will be away from the pleural effusion. This is one important thing you will have to remember. All right. Next, we talk about lung volume curves. It is usually important for step 1. I'm not going to discuss the lung volume curves. Oxygen saturation and PO2. Please do remember that the graph, again, this is important for step 1, but I'll tell you what are all the important things. Talking about the O2 saturation and partial pressure of oxygen. Oxygen saturation is usually done at 95 to 98 at the rate of 100. This is the graph we are expecting. All right. Next, we talk about DLCO. This is one important question or concept tested in USMLE step 2. Please do remember that this is a diffusion coefficient measuring your alveolar basement membrane function. What is the basement membrane function? It is making sure that the transfer of oxygen into the cells is fine and transfer of CO2 into the lung is also fine. Please do make sure whenever there is low DLCO or low diffusion coefficient, possibly there can be destruction of the basement membrane. One important thing examiner would love to ask you is emphysema is an obstructive pattern where you will find that the alveoli have been dilated and there is a basement membrane that has been weakened. That is why there is decreased DLCO. In addition to emphysema, there can also be localized fibrosis that can be developing. That is why the patients usually have decreased DLCO. Talking about the restrictive pattern, it is usually the interstitial lung disease such as sarcoidosis, asbestosis, and heart failure. Whenever there is a normal spirometry, obviously it is usually because of the decreased blood pressure. Anemia, pulmonary embolism, and pulmonary hypertension is usually showing low DLCO in a patient who have got normal spirometry. There are some conditions where you will find normal DLCO as well. Whenever there is a normal DLCO question that is asked, one important thing I would like to remember is asthma. Please do remember asthma is a reversible condition. COPD is an irreversible condition. So normal DLCO can be present in asthma. Sometimes patients with ankylosing spondylitis or patients with the chest cavity deformities, that is the musculoskeletal deformities, will be having normal DLCO. Whenever I say normal DLCO in restrictive pattern, the restrictive pattern is basically in musculoskeletal deformity. Neuromuscular disease such as motor neuron disease can also present with normal DLCO and there can be restrictive pattern. Talking about increased DLCO, the obstructive pattern is seen in asthma and morbid obesity, and there is pulmonary hemorrhage and polycythemia that is usually seen, please. Please do remember this is most important slide and the examiner can ask you. If I were you, I would remember that increased DLCO with the normal spirometry is usually seen in pulmonary hemorrhage and polycythemia. If it is asthma, it is normal DLCO. If it is chronic bronchitis, it is normal DLCO. If the examiner is asking specifically about a restrictive pattern and the examiner tells you that the DLCO is decreased, I would like to think of pulmonary fibrosis caused by asbestosis, sarcoidosis as one of the most important things I'll have to remember. Patient talking about chest wall deformities, examiner talking about chest wall deformities, I would like to consider normal DLCO with the restrictive pattern and musculoskeletal deformities that are usually seen, please. All right. Next, we talk about causes of hypoxemia and normal ABGs. Please do remember that whenever there is a hypoxemia, you will have to understand the cause of hypoxemia. What could be the reason why the patient has been having hypoxemia? Could it be hypoventilation? Whenever there is hypoventilation, there will be reduced respiratory rate because of the CNS depression and the morbid obesity. So the AA gradient will be normal. And can it correct with supplemental oxygen? Yes, it can be corrected with supplemental oxygen. Could there be reduced partial pressure or inspiratory oxygen at high altitude? And does it correct with supplemental oxygen? Yes, it can correct with supplemental oxygen as well. Next, we talk about the diffuse limitation. Whenever there is diffuse limitation, usually in examples of emphysema and interstitial lung disease, there will be AA gradient that is increased. AA gradient is nothing but the difference between alveolar to arterial oxygen, please. AA gradient is increased in patients with ILD and emphysema. And will it be corrected with supplementation of oxygen? Yes, it can be corrected with supplementation of oxygen. Now comes the most important concept where the examiner can talk to you about ventilation perfusion mismatch. Whenever there is ventilation perfusion mismatch, it is basically because of the pulmonary embolism that the examiner is talking about. Again, there can be increased AA gradient and it can also be corrected with supplemental oxygen. Talking about a large intrapulmonary shunt where there is pulmonary edema, please do remember that there cannot be AA gradient that is corrected with supplemental oxygen. The AA gradient is increased in large intrapulmonary shunt, but with supplementation of oxygen, it is not usually increased. Next, we talk about large dead space ventilation. Whenever there is large dead space ventilation, it is usually because of the massive pulmonary embolism and the right to left intracardiac shunt, which usually causes increase in the AA gradient, and this does not correct with supplemental oxygen because this is a problem related to the heart and it is basically related to massive PE. All right. Next, we talk about lung cancer screening. Remember, if any of the patient who is basically coming to your outpatient clinic in more than 55 years of age, with 55 years of age, you will have to understand that this patient, the examiner is asking a question regarding lung cancer screening. Examiner can tell you that the patient has stopped smoking 10 years ago. Still, you will have to screen this patient. All right. So smoking cessation less than 15 years back, and if the patient has stopped smoking for more than 15 years, they do not need to be screened. But what is the most important investigation you do for lung cancer screening? It is the low dose chest CT scan that you will have to do. How do you recommend it? You do it yearly. Annual scanning needs to be done, please. And when do you terminate or when do you stop the screening? If the patient is more than 80 and if the patient has quit the smoking for more than 15 years. All right. This is one important thing about lung cancer. Talking about the lung cancer questions in USMLE, I would like to tell you that most of the times.
Sorry, it's 50 to 80 now and 20 or more.
Oh, it's 50 to 80.
Here. Yeah, 50 to 80 and 20 or more smoking pack history.
Thank you. Thanks, Claudine. Thank you very much. So one of my students have told me that the age of screening has been changed. It is usually 50 to 80 years at the moment. And whenever the patient has smoked more than 20 pack cigarettes per day, it is the criteria for qualification of screening, please. All right. Thank you very much. Next, we talk about adenocarcinoma, most common adenocarcinoma. What did we discuss about adenocarcinoma? Wherever there is lining of columnar epithelium, there is adenocarcinoma, please. Patient usually presents with the clubbing. That is one important clue that the patient has developed lung cancer. Squamous cell carcinoma usually presents with hypercalcemia because of the PTHRP that is elevated. And the examiners would love to ask this question, saying that there is central necrosis and cavitation. Small cell carcinoma, the cells are very small, so they metastasize rapidly. So most of the time, small cell carcinoma is diagnosed after metastasizing. Whenever it metastasizes, it can involve any of the organs. So it can present with Cushing syndrome, SIADH, and Lambert-Eaton syndrome. This is one important thing you'll have to remember. Large cell carcinoma, you'll have to remember gynecomastia and galactorrhea are the most important paraneoplastic syndromes that are usually presenting with large cell cancer. Next, we talk about one of the most important lung cancer that is called as Pancoast tumor. Whenever the examiner is talking about Horner syndrome or examiner can talk to you about drooping of the eyelid, the examiner doesn't want to reveal that the patient has got Horner syndrome. So they can tell you that the patient has got ptosis, meiosis, anhydrosis, and enophthalmos associated with shoulder pain or the left apical involvement, the left apical pain, or there can be pain around the neck region. Please do think of Pancoast tumor, please. I'll have to show you this because Pancoast tumor, the shoulder pain is most common. Horner syndrome is basically ipsilateral ptosis, meiosis, enophthalmos, and anhydrosis. And there can be C8 to T2 neural involvement where there is weakness and atrophy of the intrinsic muscles of the hand. Pain and paresthesia of fourth and fifth digits can be seen in the medial forearm. I want you to understand that the examiner can ask you about what could be the next important step, please. Please do remember Pancoast tumor, whenever it is present, it can involve the supraclavicular lymph node and there can be weight loss as well. All right. Sometimes the examiner can give you the options of sulcus tumor. Very important, please. What is the strongest, most risk factor? It is the smoking. Can present with any of the symptoms. So please do remember this. But most importantly, I want you to remember Horner syndrome and weakness of the arm or shoulder pain is one important thing you will have to remember, please. Refer to surgery for Pancoast tumor. That is very important, please. Next, we talk about solitary pulmonary nodule. Whenever there is solitary pulmonary nodule, it must be more than 3 centimeters in diameter, please. Most of the time, solitary pulmonary nodule could be associated with any of these things: infections, granulomas, and hematomas. Sometimes, if the examiner wants you to understand that the solitary pulmonary nodule has got features of malignancy, the examiner wants you to remember or look for some of the CT findings, which is more than 3 centimeters in size. Patient has got spiculated margins. Patient has got irregular margins of the nodule. Patient has got calcifications around the nodule. All these are the important risk factors that can point out towards malignancy, please. Anything which you have to do, you'll have to do a CT scan, please. If the patient has got a CT scan findings and has got malignancy, please do refer to surgery. That is why these findings are important. I'll also tell you the examiner can talk to you about benign symptoms. What do? If there is benign symptom, you just have to do a serial follow-up with the CT scan, or you can possibly do an X-ray. That needs to be done, please. Very, very, very important, please. If the patient has got intermediate features, what do? Very important. You do not know where to go. Please do not do a CT scan. Please do not do an X-ray. You will have to do a PET CT scan if the patient has got intermediate symptoms. Intermediate symptoms are nothing but spiculated margins or calcifications that can only be present. 1 or 2 symptoms can only be present in the question. That is why the examiner is talking about intermediate features, please. All right. We will possibly discuss this solitary pulmonary nodule on chest X-ray. What do? You'll have to check previous X-rays, please. CT scan, you'll have to do. Benign features, you'll have to follow up. Intermediate features, you'll have to do PET scan. High suspicion, you'll have to surgically excise, please. The examiner would ask you about this patient high risk features, that is nodule size of more than 2.0, 2 centimeters, age of more than 60, and smoking status, currently smoking. These are the high risk features, please. All right. Next, we talk about cough, chronic cough. What did we discuss in gastroenterology? If it is a subacute cough, it is GERD, start him on PPIs. The examiner can tell you that there is subacute cough. What do? Subacute cough is nothing but, I've already discussed, whenever in medicine, if you are talking about acute, it is less than 4 weeks. If it is acute, if it is subacute, it is 4 to 8 weeks. If it is chronic, it is more than 8 weeks. We are talking about subacute cough, which is usually present in between 4 to 8 weeks. I want you to remember 3 most important causes. One is postnasal drip, another one is asthma, another one is GERD. However, upper airway cough syndrome and chronic sinusitis are the upper airway disorders which usually presents with 4 to 8 weeks of symptoms. Lower airway and parenchymal disorders usually these symptoms are because of asthma, post-respiratory tract infection, chronic bronchitis, bronchiectasis, lung cancer, and non-asthmatic eosinophilic bronchitis. Of this, I would like to remember asthma because the examiner wants you to test spirometer or spirometry as one of the most important investigation that you will have to do. Or pulmonary function test is what the examiner can tell you about patient who has got a subacute cough and is presenting with asthma. If the examiner is talking about asthma, he will tell you about night symptoms. That is why you will have to differentiate it between GERD and asthma, please. In asthma, there is wheezing. In GERD, there is no wheezing. Talking about bronchiectasis, the examiner can talk to you about multiple infections recently, or there can be immunocompromised, or there can be cystic fibrosis association if the examiner is talking about a lower airway disorder or a parenchymal disorder. Gastric esophageal reflux and ACE inhibitors, we all know that that is a cause of cough. Now we see a diagram or a flow chart. Suspected etiology on history and physical examination. You'll have to consider to stop ACE inhibitors. First generation H1 blockers needs to be given if it is upper airway cough syndrome. Pulmonary function test needs to be done if it is asthma, and proton pump inhibitors needs to be given if it is GERD. Talking about the parenchymal or any of the disorders that is commonly affecting the lungs, you'll have to consider if the patient is immunocompromised or not. If the patient has got cough with sputum, I'll certainly do a chest x-ray, please. Very important. Next, we talk about upper airway cough syndrome. We just discussed the treatment is basically first generation H1 blockers, that is diphenhydramine. All right. Post-nasal drip, 4 to 8 weeks are the symptoms, please. All right. Most of the times, upper airway cough syndrome is associated with allergic rhinitis, perennial non-allergic rhinitis, vasomotor rhinitis, acute nasopharyngitis, and sinusitis as well. All these, there can be facial pain as well. All right. Now we talk about non-allergic rhinitis. It is usually called as vasomotor rhinitis. Please do remember that itching is the first most important thing you'll have to remember for allergic rhinitis, please. For non-allergic rhinitis, there is no itching. Patient can only present with nasal congestion if it is non-allergic rhinitis. If it is allergic rhinitis, it is itching, sneezing, and some of the triggers are identified in the question. How do you diagnose it? It is usually by the history taking that we will have to consider, and family history and past history with association of atopy or type 1 hypersensitivity is one important thing you'll have to consider for allergic rhinitis. Coming back, talking about non-allergic rhinitis, it is usually the intranasal antihistamine spray that needs to be given for non-allergic rhinitis. Please do remember, if the symptoms are severe, first you give antihistamines and then you give steroids, please. Next, we talk about allergic rhinitis. If it is allergic rhinitis, I want you to consider that it is usually intranasal glucocorticoids first and antihistamines next. This is one important thing we'll have to remember. You all know pulmonary function test, obstructive disease, restrictive disease. Restrictive disease, the pulmonary function test will be of restrictive type, that is FEV1 by FVC ratio. It can be normal or it can be high, whereas in obstructive, it is usually low FEV1 by low FVC that is usually seen. Obstructive disorders, you will have to consider DLCO. If it is decreased, it is COPD. If it is increased, it is asthma, please. Normal as well. Anything which is DLCO, that is decreased in obstructive lung disorders, think of fibrosis, that is emphysema. Talking about restrictive lung disease, DLCO is usually decreased in interstitial lung disease and granulomatous disorders such as sarcoidosis and asbestosis. If the DLCO is normal, we already discussed that this could possibly be because of the neuromuscular involvement or musculoskeletal involvement. All right. This, you all know this. Next, we talk about the pulmonary function test in chronic lung disease. Remember, in asthma, it is, sorry. So in asthma, it is basically TLC, total lung capacity, that is normal or increased usually in the late stages. Whereas in COPD, total lung capacity is increased because of the obstruction. Interstitial lung disease, it is a restrictive lung disease, which usually causes decrease in the lung size, so total lung capacity is decreased. Pulmonary arterial hypertension, the parenchyma are normal, so TLC is normal. Restrictive chest wall disease, the chest cavity is small, so the total lung capacity will be decreased. Talking about FEV1 by FVC, we all know that the obstructive lung disorders, it is basically decreased, and in restrictive lung disorders, it can be normal or increased. Whenever there is fibrosis, DLCO is decreased. That's it. Game over. Do not worry much about DLCO. Whenever there is fibrosis, DLCO is decreased. All right. Next, we talk about chronic obstructive pulmonary disorder. I would like to tell you, you all know that it is smoking is the most important risk factor. Patient presents with symptoms of cough, sputum, wheezing, and barrel shaped chest and everything. I want you to understand that whenever the examiner asks you a question on COPD, there is no clubbing, please. One important question, I'm repeating this again because you'll have to remember this. There can be chronic bronchitis and emphysema. Chronic bronchitis, no parenchymal involvement is seen. Whereas emphysema, there is parenchyma involved, please. Centriacinar emphysema, panacinar emphysema is one thing you'll have to remember. COPD patients usually have got retention of retention of carbon dioxide. Patients will be hypoxic. This hypoxia stimulates erythropoietin. Patients has got increased RBC count. This is usually manifesting as polycythemia, please. So chronic hypoxemia. Next, we talk about some of the important components in chronic obstructive pulmonary disease. Why does hyperinflation or why does total lung capacity increase in COPD? You all right, doctor?
No, I just wanted to say, so anytime we see the clubbing, then we just have to look for malignancy.
That's it. Respiratory, if the patient has got COPD, and if the examiner tells you that the COPD patient develops clubbing, it is malignancy.
Okay.
All right. Why? Because patients with severe respiratory disorders usually have grade 4 clubbing. Patients with emphysema, patients with bronchiectasis, patients with cystic fibrosis, patients with Crohn's disease can also develop clubbing. But especially if the COPD patient is developing clubbing, it is malignancy until otherwise proved. All right. Next, we talk about hyperinflation in COPD. Whenever there is hyperinflation, lungs are expanded. Please do remember that it happens because of the chest wall that is expanding and the air that is not going outside. This usually leads to air stacking phenomenon. Whenever there is air stacking phenomenon, it is basically it is basically the expiratory phase that is increased, and also the need for correction of hypoxia and excessive inspiration leads to air stacking phenomenon. That is why patients do have increased size of the lungs, or total lung capacity is usually increased. All right. What is the first most important stuff you'll have to tell the patients? Stop smoking cessation is first most important thing. And then you can tell them the long-term oxygen supplementation can be given, and lung reduction therapy can also be given. All right. If you want prolonged survival in COPD after initial treatment. Now, talking about the treatment, it is usually the inhaled bronchodilators such as anticholinergics such as ipratropium and tiotropium. Anticholinergics may be combined with short-acting beta agonist, and then for severe COPD, you can use steroids and long-acting beta agonist. The examiner wants you to understand that long-term oxygen therapy, there are certain indications that you will have to remember in real life as well. If PaO2, partial pressure of the oxygen, is less than 55, yes, the patient is a candidate for long-term oxygen therapy. If the saturation SaO2 is less than 88% on room air, yes, the patient is a candidate for long-term oxygen therapy. If the PaO2 is again less than 59 with the symptoms, what are the symptoms? Again, it is a right heart failure. Why is it the right heart failure that usually we'll need to understand? Because hypoxia is a potent vasoconstrictor of the pulmonary vessels. Whenever there is pulmonary vessel constriction secondary to hypoxia in COPD, patient develops pulmonary hypertension. Whenever there is pulmonary hypertension, right ventricle fails to pump the blood. Whenever there is right ventricular failure, it usually leads to right heart failure. That is why PaO2 with less than 59, you will have to consider cor pulmonale or evidence of right heart failure. You'll have to consider long-term oxygen therapy, please. Next, we talk about chronic versus acute COPD. Simple thing is you will have to do a ABG. In acute on chronic COPD, there is a hypercarbia associated with acidosis and low bicarbonate level. This is basically because of a mixed acid-base disorder that is happening. Whereas in chronic COPD, usually there will be normal pH and there will be high serum bicarbonate. I will also have to tell you that whenever there is compensation, that is that the examiner is talking about, patients will have normal pH, please. So if the patient is got normal pH, there is a compensation going on. Whenever there is compensation going on, it usually indicates that it is a chronic problem, please. All right. Next we talk about acute. Acute exacerbation of COPD. Acute exacerbation of COPD. What is the first most important? It is not the smoking. It is the infection that we will have to consider, please. And what infection it is? It can be viral infection or it can be bacterial infection. Usually it is the upper respiratory tract infection that is the most common trigger for the exacerbation of COPD. If you want antibiotics to be started, if you think that this patient has got exacerbation of symptoms, you will have to consider worsening cough, the patient who has got increased sputum production and increasing shortness of breath are the three most important factors you will have to understand for acute exacerbation of COPD. Next, we talk about the symptoms. You all know these symptoms: wheezing, tachypnea, prolonged expiration, use of accessory muscles, jugular venous distension because of the right heart failure, distal heart sounds because of the pulmonary hypertension, and diagnosis is by chest X-ray where you find hyperinflation. But I want you to understand the treatment part of this exacerbation. Whenever there is COPD exacerbation, the initial intervention is bronchodilators, which we will have to give, and also glucocorticoids, usually prednisolone 30 milligrams for 5 days needs to be treated, please. This is one important question the examiner can ask you. Antibiotics can also be given. Next, we talk about the non-invasive positive pressure ventilation. When do you do non-invasive positive pressure ventilation? If the patient has got worsening ABG, if the patient is not responding to antibiotics, you just have to select the option of non-invasive positive pressure ventilation. Next, we talk about mechanical intubation. Whenever there is mechanical intubation, if there is failure of non-invasive positive pressure ventilation for 2 hours, and if the patient is acidotic, do not look anything. If the examiner has given you a pH of 7.1, you just go and intubate this patient. And whenever there is hemodynamic instability, airway is the most important thing we'll have to maintain. That is why mechanical intubation needs to be done. Next, we talk about poor mental status where there is somnolence, lack of cooperation, and inability to clear secretions. Patient is deteriorating, tired, then you will have to go ahead and do mechanical intubation, please. There is one most important question the examiner can ask you: what is the medication that we can use to prevent the exacerbation of COPD? All right, sounds funny, but there is this thing called roflumilast. It is usually a phosphodiesterase inhibitor, which causes decrease in the mucociliary malfunction and also decreases the pulmonary rehabilitation, pulmonary remodeling. That is why you will have to use this. That is why we can use this to decrease the future exacerbations, please. Very, very, very important. All right. Next, we talk about the indications of non-invasive positive pressure ventilation. Please do remember, whenever there is COPD which is not responding to antibiotics, you'll have to consider non-invasive positive pressure ventilation. If there is pulmonary edema secondary to cardiac cause, you'll have to use positive pressure ventilation. The basic reason why we are doing positive pressure ventilation is we are trying to keep the alveoli open. Whenever there is acute respiratory failure, post-operatively hypoxemic respiratory failure, or patients with immunosuppressed state can also be used for non-invasive positive pressure ventilation. All right. If there is pneumothorax, you must not use positive pressure ventilation. That is one important thing I want you to remember, please. All right. Next, we talk about what are all the antibiotics that are usually given for exacerbation of COPD. Whenever the antibiotics you talk, it is usually the macrolides, azithromycin, respiratory fluoroquinolones, levofloxacin, and moxifloxacin. Penicillin or beta-lactamase inhibitor such as amoxicillin or clavulanate is one thing you'll have to remember, please. All right. Symptomatic hypercapnia in COPD exacerbation. Please do remember altered mental status. Whenever the patient is confused, whenever the patient has got behavioral changes, you will have to consider, could there be elevation of CO2 that the patient is presenting with confusion. You'll have to do an ABG to identify the CO2 levels. ABG is arterial blood gas. Next, we talk about the pathophysiology. Whenever there is COPD, usually there is a retention of COPD because of the shallow breathing. And there can also be ventilation perfusion mismatch. Please do remember that you will have to make sure whenever there is symptomatic hypercapnia, you will have to treat this patient, please. And how do you treat this patient? If the patient has got symptomatic hypercapnia, you can give positive pressure ventilation, non-invasive positive pressure ventilation. All right. Most of the times, the examiner can tell you that the patient is presenting with headache, severe hypercapnia, delirium, confusion, lethargy, coma, and seizures. All these are the neuro symptoms, please. That is why in USMLE, you will have at least 30 to 40% of neurology questions. All right. Next, we talk about alpha-1 antitrypsin deficiency. All right. We'll take a break here and then we'll come back. Thank you very much. Welcome back, everyone. If you are able to hear me, just give me a thumbs up or say yes, please. Great. Welcome back. Now we'll talk about alpha-1 antitrypsin deficiency. Whenever in a question you find that there is involvement of respiratory system and liver or skin, you'll have to think of alpha-1 antitrypsin deficiency. One common question the examiner can talk to you is, patient usually develops shortness of breath or COPD on smoking minimum cigarettes, and that too at very young age. That points out towards the diagnosis of alpha-1 antitrypsin deficiency. Smokers present in 30s while non-smokers present in 40s. This is what the examiner will be talking about. It is usually associated with Panazin or emphysema, chronic hepatitis. So the examiner will tell you that the liver function tests are abnormal and there is painful erythematous nodules, that is panicolitis, please. Usually COPD presenting with the younger age is alpha-1 antitrypsin deficiency until otherwise proved. How do you diagnose this patient? It is serum alpha-1 antitrypsin levels that needs to be done, and pulmonary function test needs to be done, please. The treatment is intravenous supplementation of alpha-1 antitrypsin deficiency with the bronchodilators and the corticosteroids. What are the differential diagnoses the examiner can ask you? The first most important differential diagnosis is patient who's got asthma. Whenever there is asthma, the chest X-ray usually shows hyperinflation, and the COPD is another diagnosis. Whenever there is COPD, it is usually happening at more than 60 years of age, and in alpha-1 antitrypsin deficiency, it is the lower lobes that are involved, whereas in COPD, it is the upper lobes with the fibrosis that is seen or that is involved in COPD. All right. This is what we talked about. Next, we talk about asthma. Whenever there is asthma question, the examiner would love to test you about the treatment of asthma. Please do remember that night cough night wheezing, night shortness of breath. Whenever these are present, you will have to first rule out asthma. All right. Remember, treatment of asthma usually is in 6 steps. First step is basically short acting beta agonist. Next one, step 2 is basically a low dose ICS we use. Step 3, you can add low dose ICS with long acting beta agonist, or you can use medium ICS. This is what the examiner will be asking about. Next step, in the fourth step, you can talk about the medium dose ICS with the LABA. And in step 5, it is high dose ICS with the LABA. And you can also consider omalizumab monoclonal antibody. Step 6, you can consider ICS plus LABA plus corticosteroids and omalizumab if the patient has got allergies. But remember, it is usually the addition of omalizumab and medium dose ICS that the examiner would be asking you. All right. Talking about the asthma severity, it is usually divided as intermittent, mild persistent, moderate persistent, and severe persistent. Please do remember, most of the times it is moderately persistent question the examiner will ask you, because it is usually more than one time a week the patient usually wakes up and the therapy is indicated with step 3, that is medium dose ICS needs to be given. Next, we talk about exercise induced bronchoconstriction. Exercise induced bronchoconstriction is basically because of the passage of the cold air and dry air that triggers mast cell degradation, causes bronchoconstriction. Please do remember that patients with asthma can have exercise induced bronchoconstriction. So the examiner would ask you, what is the most important treatment? If the treatment is asked, it is usually a SABA, that is albuterol. And when do you use it? It is 10 to 20 minutes prior to exercise. If the patient is not able to tolerate beta agonist, anti-leukotriene agents needs to be given within 10 to 20 minutes before exercising, please. Sometimes you can also use inhaled corticosteroids, and sometimes you can also use short-acting beta agonists and anti-leukotriene agents in patients who are doing marathons. This is what the examiner will ask you, please. All right. Yeah, we've got it here. SABA, anti-leukotrienes, inhaled corticosteroids, and only few times a week SABA is the first line. If the patient exercises daily, you can usually use inhaled corticosteroids or anti-leukotriene agents, please. Next, we talk about aspirin-induced respiratory disease or aspirin-exacerbated respiratory disease. It is basically because of the predomination of 5-lipoxygenase pathway, where it can cause bronchospasm by thromboxane A2 and PGD2. This is what you'll have to remember. It is also called as pseudo-allergic reaction. Please do remember, this is not IgE mediated reaction. So antihistamines and steroids will not work, please. All right. Most of the times it is basically because of the inhibition of COX-192 and also activation or excessive activity of 5-lipoxygenase with thromboxane A2 production and PGD2 production that causes bronchospasm. All right. Very important, please. All right. Next, we talk about the treatment and management of asthma, and if you want to do the treatment for patients with aspirin exacerbated respiratory disorders, please do make sure that you avoid NSAIDs. One important thing, desensitization of NSAIDs can be done. But remember, it is the leukotriene inhibitors and leukotriene receptor antagonist that plays an important role. So examiner will give you montelukast in the options after the patient develops aspirin exacerbated respiratory disease, please. All right. What are the differentials? It is the anaphylaxis. In anaphylaxis, it is skin involvement that is usually seen because of the mast cell, and IgE activation is usually seen in anaphylaxis. All right. Next, we talk about ventilatory response in asthma exercise. Please do make sure that whenever there is asthma exacerbation, I want you to first concentrate on the treatment, please. Obviously, this is a reversible cause. Asthma is a reversible respiratory disorder, so patient usually have not got any fibrosis, but whenever the patient has got asthma, it is usually the increase in the respiratory rate that happens. Whenever that respiratory drive happens, it usually results in hyperventilation. Most of the CO2 is lost. That is why patients develop respiratory alkalosis. Whenever the patient develops respiratory alkalosis, you'll have to also consider that patient can be at risk of impending respiratory failure. And remember, patient can also present with absent wheezing if the patient has got a severe exacerbation of asthma. This is one thing you'll have to remember, please. Next, we talk about management. When it is mild to moderate asthma exacerbation, it is basically oxygen, short acting beta agonist, and systemic corticosteroids that you need to give, please. If the patient is not responding, you'll have to go ahead and add ipratropium nebulizer and systemic corticosteroids and one-time IV infusion of MgSO4. This is one important thing you'll have to remember. But the examiner can ask you what is the most important step you'll have to do. It is the endotracheal intubation, please. Asthma exacerbations do not need antibiotics because asthma exacerbations are basically because of the pollen or the hypersensitivity reaction, but not because of the bacteria or viral infections. That is why antibiotics are not usually necessary for the exacerbation of asthma. Sometimes there can be asthma exacerbation secondary to GERD. What do you have to do? You will have to consider PPIs, please. What is the most important thing the examiner can ask you? There cannot be wheeze, but there can be sore throat, there can be morning hoarseness, and there can be worsening cough at night. This is one thing you'll have to remember again, please. All right. Next, we talk about atelectasis due to asthma exacerbation. Whenever there is atelectasis secondary to asthma exacerbation, please do remember that it is basically because of the mucus plug the examiner is talking about. All right. Next, how do you differentiate the test for asthma and COPD? You'll have to make sure that you do spirometry before and after administration of a bronchodilator. This is one important thing you will have to remember, please. All right. Next, asthma versus COPD. If we do asthma, this is asthma, COPD, and late stage COPD. All right. FVC will be normal and normal, but FVC is decreased. FEV1 can be decreased in both, but more decreased in late stage COPD. FEV1 by FVC is decreased in all, but most decreased in late stage COPD. Examiner would ask you this question because late stage COPD is associated with fibrosis. All right. Next, we talk about anaphylaxis. Please do remember there are two important questions the examiner can ask you. One is anaphylaxis, where it is associated with wheezing. Another one is focal body or foreign body ingestion. Whenever there is foreign body ingestion, patients develop focal wheezing. This is diffuse wheezing in anaphylaxis. Examiner will ask you that the patient or the child has been playing out of supervision from the mother and is now presenting with shortness of breath and something like that, but there is only wheezing at only lower part of the lung. It is usually foreign body ingestion that we will have to consider. If it is anaphylaxis, it is basically wheezing that is usually present throughout the chest. One thing you'll have to remember, please. Anaphylaxis, whenever it is present, it can manifest systemically by involving cardiovascular problems such as hypotension, edema. There can be stridor, hoarseness, increased respiratory rate, and wheezing as well. What is the treatment you'll have to do? You will have to go ahead and give intramuscular epinephrine to make sure that the airway management is very important in this. All right. Next, we talk about interstitial lung disease. Whenever there is interstitial lung disease, I want you to consider that patient usually presents with dry cough, with crepitations on examination, at basis, not changing on cough. Why? Why is this important? Because crepitations, changing on cough, is bronchiectasis. All right, this is one important thing you'll have to remember, please. All right, next we talk about interstitial lung disease. Whenever there is interstitial lung disease, it is usually in the pulmonary interstitium or in the alveoli that the examiner will be talking about. Dry cough with the presence of crepitations, you'll have to consider that. If it is an X-ray finding, the examiner will tell you that there is reticular opacities, please. If it is pulmonary function tests that are involved, it is usually the restrictive pattern of the disease that is usually seen, and decreased DLCO is commonly seen, please. All right. Most of the times, the causes of the respiratory lung disease, interstitial lung disease can be multiple. All right. So please do remember that the presentation is important rather than the cause. But I'll also have to tell you some of the important questions that can be asked for USMLE step 2. Sarcoidosis causes interstitial lung disease. Patients with vaginas causes interstitial lung disease. Occupational therapy, asbestosis causes interstitial lung disease. Patients with SLE can cause interstitial lung disease. If the cause is not identified, it is idiopathic pulmonary fibrosis. Cryptogenic organizing pneumonia is a common cause of restrictive pattern of the lung disease. This is one thing you will have to identify, please. Asbestosis, there is one simple thing you will have to remember. Asbestosis, whenever it is present, the examiner will tell you about pleural plaques on chest imaging. I want you to understand that asbestosis is a occupational lung disorder where there is base of the lungs that are involved and becomes a fibrosis. Most commonly asked question is patient of the 50-year-old and is got 25 years of smoking history. What do you do, please? What happens? The increase in bronchogenic cancer increases, and how many times? It is usually 10 times more. That is 50 times more. 5 into 10 times more, 50 times more. There will be increased risk of bronchogenic carcinoma. In asbestosis, the examiner will tell you that the patient is from mining, the patient is from shipbuilding, the patient is working at a insulation, doing a insulation work. These are all the things the examiner can talk to you about. All right. Most of the times, asbestosis, whenever it is presenting with, it usually presents with progressive dyspnea over periods of month. And I'll also have to tell you there can be digital clubbing as well. X-ray shows interstitial abnormalities, pleural plaques, and restrictive pattern where there can be where there can be decreased DLCO and decreased pulmonary compliance, please. All right. What is the most important thing you'll have to remember? Bronchogenic carcinoma versus mesothelioma. If it is a smoker, it is bronchogenic carcinoma, that is more common. If it is a non-smoker, it is mesothelioma, that is more common. However, I'll also have to tell you mesothelioma is very, 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 very rare. And how does mesothelioma present? It is usually pleural abnormality, and there will be so much of fluid that is causing mesothelioma, which can lead to pleural effusion or ascites. This is one thing you'll have to remember, please. All right. Next, we talk about the causes of hemoptysis. Anything can cause hemoptysis, but the most important thing is lung cancer, bronchiectasis, bronchitis in pulmonary, and mitral stenosis is one important thing you'll have to remember, please. Everything else is the same. If we talk about the hematological malignancies that can cause, it is coagulopathy, whereas in renal disorders, it is usually the granulomatosis with polyangiitis and good pasture syndrome. I'll also have to tell you that good pasture syndrome is usually hemoptysis with hematuria. Granulomatous polyangiitis is hematuria with epistaxis. This is one thing you'll have to remember. Whenever there is vaginous disease, it is C. anca that is positive. All right. Patient can present with abdominal pain, recurrent urinary tract infections, epistaxis. All these are the conditions pointing out towards Vaginous granulomatosis, please. This is what the examiner will ask you in the question. All right. We will now talk about some of the important concepts or questions regarding pulmonary embolism. Claudine, you have already told me that it is Wells score that we calculate. We'll discuss more about Wells score in this one. Pulmonary embolism, if the patient is got a long haul flight, patient has got obesity, patient is on OCP, patient is on estrogen, patient is on progesterone, patient has got family history of coagulopathy, patient has got atrial fibrillation. All these are the risk factors for the development of pulmonary embolism. But the most important thing is the patient develops hemoptysis, there can be tachycardia, and there can be low grade fever. If there is unexplained tachycardia in the question and the CRP is 1, what do you have to rule out? It is pulmonary embolism, because if the CRP is raised, it is usually infection. If the pulmonary embolism, it is not the infection that is raised, but it is the D dimer that is usually raised. Patients will talk about malignancy. Patient will talk about decreased immobility. These are all the things the examiner can talk to you about. Sometimes, in order to divert you, the examiner can talk to you about hemoptysis or likely cancer. What do? You'll have to think of pulmonary embolism. Why is the examiner talking about tachycardia? Why is the examiner talking about malignancy or patient who has got a recent surgery or anything? Because all these comes under the risk factors, and these risk factors are basically used to develop a Wells score. Talking about the Wells score, I'll also have to tell you that if the patient has got Wells score, it is usually the clinical signs of DVT. If it is present, it is plus 3 points. And if it is an alternate diagnosis that is less likely, it is again a 3 points. If the patient has got heart rate, if the patient has got surgery, it is 1.5. If it is hemoptysis and cancer, it is 1. If it is less than 4, it is pulmonary embolism unlikely. If it is more than 4, it is pulmonary embolism likely. If it is pulmonary embolism likely, the examiner wants you to go and treat with the CT pulmonary angiogram. If there is no CT pulmonary angiogram, you will have to give in enoxaparin or low molecular weight heparin, please. Very, 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 very important. If there is PE that is unlikely, what do you have to do next? It is the D dimer that you will have to test, please, if the patient has got risk factors. That is one important thing you will have to remember, please. Now comes the most important ECG finding. The common ECG finding is sinus tachycardia. Most common ECG finding is sinus tachycardia. But the characteristic ECG finding is S1Q3T3. This is one important thing you'll have to remember, please. Okay, if the patient has got suspected pulmonary embolism, we will have to stabilize the airway and oxygen in IV fluids and oxygen, and then you'll have to consider if the patient has got any contraindications. If there are any contraindications, you will have to make sure that you consider IV filters, not use anticoagulation. But depending on the Wells criteria, if the PE is likely, you'll have to consider anticoagulation, especially if the patient has not got any contraindications. If the patient has got a PE unlikely, you do further tests and then you can continue anticoagulation. If the patient has not got any further imaging that is positive for, if he's not got any positive signs on imaging, you can stop the anticoagulation. But the reason the examiner would ask you is, if the patient has got a likely Wells score of more, what is the next best step? You do CT angiogram. If the option of CT angiogram is not given, you go ahead with anticoagulation. If the patient has got both options, CT angiogram and pulmonary CT angiogram and anticoagulation, choose anticoagulation if the Wells score is more than 4. That is one important thing you'll have to remember. Acute massive PE, whenever there is acute massive PE, what happens? The right ventricle will not be able to pump blood, so right ventricle outflow happens. So right ventricle hypokinesia, hypodilation happens, resulting in the right heart failure. That is why you will have to consider thrombolysis or urgent treatment if the patient has got any massive PE. If the patient has got massive PE, it is inevitable that the patient will develop hemodynamic compromise. So please do make sure you treat the patient immediately. All right. If the patient has got signs of hemodynamic compromise, it is usually The thrombolysis we usually do with altiplase. There is something called wedge shape. There is something called pulmonary embolism at the bifurcation. Whenever there is bifurcation, it is usually considered as an acute massive PE. So you'll have to treat the patient immediately with the enoxaparin, or if the patient develops hemodynamic compromise, you can just go ahead and give IV, subcutaneous Clexane, please. Very, very, very important. All right. We now talk about pulmonary infarction. Whenever there is pulmonary infarction, please do remember that the tissue is crying because of the lack of blood supply. So patient develops chest pain, dyspnea, mild fever, and leukocytosis with the hemoptysis. Whenever there is pulmonary infarction, you diagnose this by CT scan, please. How do you diagnose this? This is a wedge-shaped thing you will have to remember, please. All right. Next, we talk about the differential diagnosis, please. Very important. It is bacterial pneumonia, usually not wedge shaped, but rather than it is basically around the blood vessel supply. We usually see lung cancer. If we see it is usually rounded or speculated mass, the examiner can talk to you about. Next, we talk about pneumocystis pneumonia seen in HIV patients, and tuberculosis. We find cavities. Next, we talk about nitrofurantoin induced pulmonary injury. Please do remember nitrofurantoin, it is a drug, so eosinophilia will be elevated, and there can be possibly interstitial lung disease in chronic use, and there can also be acute hypersensitivity pneumonitis with nitrofurantoin. This is one important thing you'll have to remember. Talking about hypersensitivity pneumonitis, it is usually the bird fancier's lung disease or farmer's lung disease that is usually associated with the sudden development of cough, breathlessness, fever, and tiredness. How do you diagnose this? On the chest x-ray, you will see there are ground glass opacities, and on the lung spirometry, it is usually the restrictive pattern the patient usually develops. How do you treat it? You will have to avoid the allergens. All right, this is one important thing for hypersensitivity pneumonitis, please. On the lung spirometry, it is the restrictive pattern that we usually see in patients with hypersensitivity pneumonitis. Acute bronchitis, this is only the bronchi that are involved. There is no business going on in the parenchyma, so do not treat with antibiotics. This is one important thing you will have to remember, please. It is only the symptomatic presentation, symptomatic treatment that we'll have to consider. Acute bronchitis, if there is cough lasting for more than 5 days without any sputum production, we'll have to consider acute bronchitis, please. Very, very, very important. The examiner can ask you about the treatment. What treatment do you use? It is usually the symptomatic treatment. Throat lozenges and dextromethorphan can be used, please. Inhaled bronchodilators can also be used, but antibiotics should not be given in acute bronchitis, please. Next, we talk about chronic bronchitis. This is usually a manifestation of COPD. Please do remember, whenever the patient develops 3 consecutive months of productive cough in 2 successive years, it is chronic bronchitis, please. Cigarette smoking is the most important cause for chronic bronchitis. All right. When we talk about the chronic bronchitis, the examiner will ask you regarding this pulmonary function test shows obstructive pattern, and there can be normal DLCO. The differential diagnosis lies here. It is the bronchiectasis that needs to be understood, because the patient can present with the recurrent infections, and there can also be crepitations that are changing with coughing on examination. Patients can produce daily amounts, copious amounts of mucopurulent sputum in patients with bronchiectasis, please. All right. Next, we talk about oh God, what happened? Uh, So most of them are step 1 concepts. I'm just taking it off. Just give me a minute, please. Are you able to see the screen, please? Hello?
Yes.
Great. Thanks. Now we talk about pneumothorax. Obviously, there will be hyperresonance on percussion. I'll tell you one important thing. Tall, thin, young, male, smoker. Please consider pneumothorax if the patient has got sudden onset of shortness of breath. This is one important thing you'll have to remember, please. Talking about types of pneumothorax, it is spontaneous pneumothorax with normal lung, and if it is complicated or tension pneumothorax, patient is usually presenting with worsening shortness of breath and hemodynamic instability. That is one important thing you will have to remember. How do you treat the patients with spontaneous pneumothorax and tension pneumothorax? If it is spontaneous pneumothorax, it is usually less than 2 centimeters. Don't do anything, just do observation. If it is large and if the patient is stable, it is a needle aspiration that we will have to do. If the patient has got tension pneumothorax, urgent needle decompression needs to be done in patients with tension pneumothorax. This is one important thing you'll have to consider, please. Next, we talk about granulomatosis with polyangiitis. Please do remember patients presents with sinusitis and hematuria with involvement of kidneys showing rapidly progressive glomerulonephritis. Most of the times it is C-onca that is present, and the examiner can tell you that there is a leukocytoclastic vasculitis usually seen in the skin, and there can be pauci-immune glomerulonephritis in the kidney. This is how you will have to consider vaginous granulomatosis, and the management is basically corticosteroids and immunoglobulins. Sometimes you can use methotrexate, very important, please. Methotrexate with cyclophosphamide for vaginous granulomatosis, please. All right. Next, we talk about classification of pneumonia. Whenever there is classification of pneumonia, it is community hospital and ventilator acquired. For everything, it is more than 2 days. That's it. For community, the patient usually develops in a non-hospital setting. All right. Repeat chest X-ray following pneumonia to rule out malignancy after 6 weeks. And then ventilation perfusion in the pneumonia. Usually what happens is the alveoli become filled with the inflammatory exudate. Whenever the alveoli become inflamed, whenever the alveoli are filled with inflammatory exudate, what do? You will have to make sure that there is no hypoxemia. The alveoli which become filled with the exudate, there will be decreased oxygen, and this oxygen usually impairs the alveolar ventilation. Whenever the alveolar ventilation is impaired, there usually happens right to left intrapulmonary shunting, which leads to ventilation perfusion mismatch, please. All right. Sometimes FiO2 can correct the hypoxemia, but if the patient has got large intrapulmonary shunting, it would be very difficult to correct the intrapulmonary shunting, please. All right. Next, we talk about ventilation, effect of positioning in pneumonia. Whenever there is effect of positioning in pneumonia, I'll have to tell you if the affected lung is upwards, what happens? There will be decreased blood flow to the affected lung, and there will be increased blood flow to the unaffected lung. So this is a desired position. If the patient has got affected lung that is downwards, what happens? There will be more blood to the affected flow, which we usually doesn't need. So there will be lot of blood that is going on. So the patient will be having increased blood supply or increased blood flow with decreased gas exchange when there is affected lung that is present or facing downwards, please. Whenever there is pneumonia, you'll have to calculate curve 65. If the patient has got a 0 score, it is outpatient treatment. If it is 1 to 2, it is
Sorry,
inpatient
doctor.
treatment.
So the affected lung should be upwards. Is that how the position should be?
Yes, that's right. The
Okay,
affected
okay.
lung needs to be upwards, please.
Upwards.
Whenever there is
Okay.
affected lung that needs to be upwards, the normal lung usually
Yes. I remember.
Yeah, because you are decreased VQ.
Yeah,
Yes, and
exactly.
also gravity, right?
Yes, that's right.
Mhm.
Yeah. Now we talk about curve 65. We all know that confusion, urea, respiratory, blood pressure, and age 65. Whenever there is blood pressure of less than 90, systolic blood pressure of less than 90, go and treat the patient as an inpatient, please. That's it. Hemodynamic instability, you can't discharge the patient. Simple common sense. All right. 1 to 2, treat the patient as inpatient. 3 to 4, it is ITU if it is possible, please. Next, we talk about recurrent pneumonia. I already told you that the patient needs to be diagnosed or differentiated or ruled out from neoplasm bronchiectasis or a foreign body situation. Patients with alcohol, seizures, malnutrition, HIV also needs to be differentiated if the patient is presenting with the recurrent pneumonia. Next, we talk about aspiration pneumonia. Please do remember, whenever there is aspiration pneumonia, the examiner can talk to you about altered consciousness, partying, uh, students, no fixed about alcohol, malnutrition, upper gastrointestinal tract, ITU admissions, hospital admissions, patients has got impaired swallow. These are the reasons why patient can develop aspiration, please. Aspiration pneumonia is usually seen. Whenever there is aspiration pneumonia, I want you to understand there is a foul smelling cough, there is recurrent pneumonia, along with necrosis and abscess formation. You'll have to treat it with clindamycin and amoxicillin clavulanate, please. All right. Talking about the treatment of community-acquired pneumonia, it is usually macrolides and doxycycline or fluoroquinolones and beta-lactams. If the patient is in inpatient non-ITU, it is fluoroquinolone IV, or you can also use beta-lactams plus macrolides. If it is inpatient as an ITU, it is beta-lactam with macrolides and beta-lactams with fluoroquinolones that you will have to consider, please. All right. Next, we talk about parapneumonic effusion. Whenever there is parapneumonic effusion, there are two most important things you'll have to consider: transudate and exudates. For me, transudate is basically congestive heart failure, uh, cirrhosis, and nephrotic syndrome. This is what I will have to consider if it is transudate. Everything else is exudate. That is what I remembered, please. All right. Next, we talk about the Lights criteria. The protein in transudate is usually less than 0.5, whereas the protein is more than 0.5. LDH, it is usually 0.6, and in exudates, it is more than 0.6. The common causes are transudate versus exudate. It is hypoalbuminemia and congestive heart failure, whereas the exudate is again infections, pulmonary embolism, malignancy. The pulmonary embolism, we do not consider it as exudates, because pulmonary embolism can cause both transudate and exudate fluid, please. All right. Next, we talk about pleural fluid glucose. Pleural fluid glucose of less than 60 is seen in rheumatoid, and sometimes it can also be seen in complicated parapneumonic effusion with bacteria, please. I'll also have to tell you that pleural effusion with amylase is usually seen in esophageal rupture and pancreatitis. We already discussed this, and the normal pleural fluid pH is 7.6. Transudative pleural fluid is 7.4 to 7.5. Exudative is 7.3 to 7.5. Sometimes the examiner can also talk to you about a pleural fluid pH and can talk to you about what could be the cause. If the patient has got a pH of 7.3, it is usually by the cells and the bacteria, that is empyema. For you to diagnose empyema, pH must be less than 7.3, please. Very, very, very important. All right. Next, we talk about causes of pleural effusion. Again, it is transudate and exudates, congestive heart failure, cirrhosis, nephrotic syndrome, and peritoneal dialysis. It is transudate. Everything else is exudate, please. All right. Next, we talk about tuberculous effusion. Obviously, this is an infection, so there will be exudative, so there can be moderate, there can be elevated protein with lymphocytosis. LDH is increased, pH is decreased, and there can be decreased glucose because the bacilli can eat away or consume all the glucose. Next, we talk about chylothorax. It is basically rupture of the thoracic duct, which usually contains triglycerides. So pleural effusion has got increased triglycerides, please. This triglyceride content is non-inflammatory. So whenever there is non-inflammatory fluid in the thorax, they usually does not present with fever, please. All right. Next, we talk about diagnostic thoracocentesis not needed. Whenever there is a pleural fluid that needs to be taken, please do take it and you will have to examine. Next, we talk about bronchiectasis. Whenever there is bronchiectasis, we just discussed that patient usually has got multiple infections and then there will be impaired bacterial clearance where it can lead to
Sorry,
bacterial overgrowth.
I didn't see the previous slide. Can I
No,
just see?
I didn't tell you the previous slide. Hello?
Yeah, I thought you said something important. Okay, you just
No,
went
I just told that diagnostic thoracocentesis, it is usually the first
Sure.
step you'll have to do if you are thinking of pleural effusion to determine the cause. That is what I was saying.
Thank you.
Yeah, not needed. Okay. Bronchiectasis, remember, it is the recurrent infection. It is the infectious insults and patient can present with bacterial clearance as well. Patient usually has got bacterial overgrowth with the neutrophil infiltration, inflammation, tissue damage and destruction that leads to genesis of the genesis of bronchiectasis. Very, very, very important. The most important thing is patient usually presents with hemoptysis, large amounts of mucopurulent sputum, and patient presents with fatigue. On examination, patients do have clubbing. This is one important thing you'll have to remember. Whenever there is linear atelectasis on X-ray, you will have to consider bronchiectasis, please. Dilated, thickened airways are usually seen on the CT scan. The differential diagnosis is chronic bronchitis with less sputum production. That is the most important differentiating point for bronchiectasis, please. All right. Next, we will talk about the bronchiectasis secondary to cystic fibrosis. Obviously, cystic fibrosis, there will be impaired clearance and there can be decreased immunocompromised as well. So, patient usually have got bronchiectasis but the predisposition for development of Pseudomonas aeruginosa bronchiectasis is more common. Remember, upper lobe involvement is more common in patients with cystic fibrosis and bronchiectasis. Now we talk about laryngeal edema. Whenever there is laryngeal edema, it is usually hypersensitivity reaction happening suddenly. One most important thing, please, you'll have to treat it with epinephrine, systemic corticosteroids, and antihistamines. All right. Next, we talk about etiology of hyponatremia. We've talked in SIADH. We've talked in endocrinology. Now we talk about sarcoidosis. Please do remember, whenever there is sarcoidosis, there must be bilateral hilar lymphadenopathy. If the examiner is not talking about bilateral hilar lymphadenopathy, the examiner can talk about pulmonary infiltrates, but the patient is presenting with cough, dyspnea, chest pain, and is an African American that is been living, and pathology has been non-caseating granuloma. He will give you every clue except for bilateral hilar lymphadenopathy. It is your job to identify sarcoidosis. Consists of not only bilateral hilar lymphadenopathy but also pulmonary reticular infiltrates, please. Most of the times it is the UVO parotid fever the examiner can ask you. Sarcoidosis can usually present with hypercalcemia, so please make sure whenever the female patient presenting with the cough and hypercalcemia without clubbing, it is sarcoidosis until otherwise proved. High ACE levels are usually seen in sarcoidosis, please. All right, what is the treatment of sarcoidosis? It is the steroids. When you give the steroids, what do? You'll have to monitor blood glucose, please. Very important. The examiner can tell you about the manifestations of sarcoidosis because it is a multi-system involvement. Pulmonary, it is bilateral hilar lymphadenopathy and interstitial infiltrates. If it is skin, there can be papillar, nodular, plaque-like lesions and erythema nodosum as well. Ophthalmic eye, it is usually anterior uveitis, posterior uveitis, and reticuloendothelial, it is usually splenomegaly that needs to be understood, please. Anything can be involved. Cardiovascular, it is usually 30-year-old female or a male that is presenting with atrioventricular block that needs to be understood. Patient presenting with sudden onset of facial nerve palsy with bilateral hilar lymphadenopathy, you will have to consider sarcoidosis as one of the most important things, please. All right. Next, we talk about obstructive sleep apnea. Whenever the patient is sleeping, there is obstruction going on because of the fall back of the nasopharynx, and then the patient develops retention of the CO2. Patient develops a closed airway in obstructive sleep apnea. So the patient usually develops a daytime sleepiness, morning headaches, poor judgment, and depression. with the history of smoking. That is why obstructive sleep apnea is important. It is basically the obese patients that develop obstructive sleep apnea. Excessive alcohol intake at night can also cause obstructive sleep apnea. The most important examination you do is patient is obese. Whenever the patient is obese with increased neck girth, it is usually obstructive sleep apnea until otherwise proved. The reason patients develop hypertension in obstructive sleep apnea is patient who has got closure of the nasopharynx, usually the oropharynx, usually develops hypoxia. This hypoxia is a potent vasoconstriction, so it acts on the systemic vessels and releases and causes vasoconstriction. That is why patient usually develop systemic hypertension. That is one important thing you'll have to remember. And how do you diagnose? It is the nocturnal polysomnography, where you will find more than 5 obstructive respiratory events that needs to be done, please. The treatment is basically weight reduction is one important thing you'll have to remember. Avoidance of sedation and alcohol, and avoidance of supine position during sleep. The definitive treatment is again weight loss, but surgery can also be done, such as uvulopalatopharyngoplasty, and nasal continuous positive airway pressure can be done, please. Most of the times tracheostomy needs to be done if the patient fails all modalities, but do not go for the option of tracheostomy whatsoever the examiner has given you, please. Do not go for tracheostomy. It is maximum uvulopalatopharyngoplasty that needs to be done, because there are modern treatments of amazing non-continuous positive airway pressure devices we give to patients for obstructive sleep apnea. So my go-to choice is, first step is weight reduction. Next step is non-nasal continuous positive airway pressure. If it is not responding, it is uvulopalatopharyngoplasty, and then it is tracheostomy. If you want to treat the patient, if you want to surgically operate the patient, you will first have to make sure that the patient is well enough stable and is able to tolerate the surgery. So surgeries are never ever the first line in patients with obstructive sleep apnea. Now we talk about differentials of obstructive sleep apnea. Given that this patient has got systemic hypertension, patient usually develops paroxysmal nocturnal dyspnea in left heart failure, whereas you cannot see it in obstructive sleep apnea. All right. Sorry. Sorry. Next, we talk about obesity hypoventilation syndrome. I'll tell you in detail of obesity hypoventilation syndrome. Whenever there is obesity hypoventilation syndrome, usually hypoxia and hypercapnia is present throughout the day. Because of the obesity, there is hypoventilation that is going on. So patients usually develop pulmonary hypertension compared to systemic hypertension, whereas in obstructive sleep apnea, it is usually the systemic hypertension that the patient can develop, please. All right. Next, we talk about obesity hypoventilation syndrome when the patient has got BMI of more than 30 and hypercapnia, that is daytime of PaCO2 of more than 45. It is obesity hypoventilation syndrome that is usually seen. I want you to understand that ABG on room air shows hypercapnia and normal AA gradient. I also want you to understand that nocturnal positive pressure ventilation is the first line treatment with weight loss in most of the times. This is one thing you'll have to remember, please. Next, we talk about hyperventilation syndrome. I like to tell you that in our neurology clinic, whenever the patient presents with the tingling and numbness, we usually do this test. We usually do not do, but the old age consultants usually do this test of hyperventilation syndrome, where the examiner asks the patients to do hyperventilation at least 30 breaths. And then the patient develops to start paresthesia, tingling, numbness. And then the examiner will say, okay, you can stop it. And then that is how they diagnose hyperventilation syndrome previously. But please do remember, whenever there is hyperventilation syndrome, usually neurological symptoms predominate because of the cerebral vasoconstriction that happens in hyperventilation. And there can also be alkalosis induced hypocalcemia and hypophosphatemia. This is the reason why hyperventilation syndrome produces neurological symptoms. All right. With this, we complete our respiratory. I'll talk to you about rheumatology or musculoskeletal system tomorrow, and we'll discuss so many things about respiratory in rheumatology. Thank you very much. I'll see you in the next session.
Thank you.
Thank you.